Okay, I think we'll get started now. Thanks everyone for being here today. Our presenter today is Natalya Kostandova, who is a PhD student in the epidemiology department and also MHS in biostatistics, right? Yeah. So thank you for being with us, Natalya, and I'll hand it over to you.
Thank you. And thank you for giving me the opportunity to present this work. I'm really looking forward to getting some feedback. There's still a lot of things, and as you'll see, to iron out. So I really appreciate it, having an opportunity to get some of your suggestions. I will share my screen. Okay. So today I'd like to present on one of the projects that we're working on, which is evaluating impacts of attacks on healthcare in Central African Republic. And this is really quite an informal thing. So please, if you have any questions, just interrupt. This project, sorry, it's stuck. Can you see the slides moving?
No, not moving yet.
Oh boy. Sorry. I'll try to reshare again.
Yeah, take your time. No problem.
Okay. My computer is also ready for the holidays, so it's been having some technical difficulties in the past few weeks. Try to reshare again. Okay, I think it's working now. Okay, so I'll quickly introduce a little bit of a background and the context in which this project is set, and then focus a little bit on the aims and methods, give a sneak peek of the data, and then discuss some of the strengths and limitations. If there is some time and interest, we can also go into some of the data quality review and assessment that we had done for this project, but that really is kind of a bonus depending on how much time this will take. So as a background, the project is centered in the Central African Republic, which has been experiencing conflict since 2012. The conflict is ongoing. There are some times when it will strengthen, other times that it will web, and there will be some temporary peace. But really, since 2012, that conflict has been ongoing. But in 2019, it has been estimated that over 80% of the territory of the Central African Republic is controlled by the armed groups. And that has huge implications in access and utilization of healthcare, as well as more structural access to food and basic services. Over 1.3 million people are estimated to have been displaced, with about half of those being displaced outside of the country, so into the neighboring countries of Chad, Cameroon, the DRC, South Sudan, Sudan, and Congo, whereas about 50% of that is displaced internally within the Central African Republic. Now, this internally displaced population is usually found either in formalized settlements and camps or scattered around the host community. And it's still not moving to the next slide. I'm so sorry. I don't know why this is not working.
Yeah, no problem. Don't worry about it.
Okay. Okay. If it keeps doing that, I may just have to click through and then maybe zoom in or something.
Yeah, that's a good idea.
Okay. And so one of the facts that has been observed in the Central African Republic is that in the last few years, especially, there have been many more attacks that have been targeting civilian population, as well as attacks specifically on healthcare. Now, in the last 3 years, this number has remained relatively stable, around 300 incidents against healthcare that have been reported. However, the severity of these attacks, as far as the consequences of the attacks, has increased. So the attacks have been becoming more violent. And it is also known that the number of attacks that is actually reported is only a tip of the iceberg. It's hard to estimate what the actual number of attacks is, but estimates range anything from the number of reported attacks being between 10% up to about 30–40%. So we can estimate the number of incidents is actually a lot higher. In Central African Republic, the question remains of how do we even identify what the attacks of healthcare is. And so for the purposes of this project, we defined these attacks as attacks on facilities, staff, patients, bystanders, including caretakers and visitors of the patients that are in the health facilities, as well as medical transport. And this may mean medical transport that's either a formal medical transport, like a well-marked ambulance, or it can be transport that's being used to transport individuals who are seeking care, such as women who are getting ready to deliver, or individuals who are presenting for care for severe malaria. This can be physical or through intimidation and threats. In the CAR, the most common types of attacks are pillage and looting of health facilities and materials, which may include things like cold chain, malaria medication, etc. Attack on medical transport, physical attack of health personnel, which may include things like kidnapping and murder, as well as patients and bystanders. Attack of non-governmental organization offices and staff lodging, and usually this results in burglary as well as some physical attacks on the NGO staff. Road barriers, which limit access of both patients and staff to the facilities. And intimidation of patients, especially alongside the ethnic and sometimes religious lines, as well as health personnel. Now, this project is a part of a larger consortium, which is composed of these academic institutions, as well as Organization and Security Insight, which helps monitor some of the attacks on healthcare, as well as other humanitarian organizations and individuals. It comprised of multiple case studies, of which this particular focus on the Central African Republic is just one. But it is all tied by a common thread of trying to identify what methods can be used to evaluate the impact that these attacks on healthcare have. So oftentimes we have information on short-term effects. For example, an attack on health personnel may result in the death of that personnel. But what does that mean long-term? How does that affect the health of the population, as well as access and utilization of healthcare services? So that is kind of the question that we are hoping to answer in this particular case study of the Central African Republic. Let's just skip this part. So the overall objective is to evaluate impact of attacks on healthcare in CAR on specifically 3 different lines. The first is utilization of key health and nutrition services. Second is vaccination coverage and outbreak of vaccine preventable diseases, and access to and utilization of services for people living with HIV/AIDS. Now, the geographical scope of this project covers 3 sub-prefectures in the Central African Republic that you will see highlighted on this map. So we have the sub-prefecture of Otkoto in the north. We have the sub-prefecture, sorry, this is the Wakaga. Then you have the sub-prefecture of Otkoto and Waka. These are 3 sub-prefectures in which there have been a lot of conflict and quite a bit of violence, including that against healthcare. The reason why we had selected these 3 particular sub-prefectures is that these are the sub-prefectures that are supported by an NGO, International Medical Corps, with which we have a well-established partnership. So this will come especially apparent when we discuss the data sources. But essentially, we are more likely to get solid information from all sides about the attacks, as well as about the health services and population information because of this well-established relationship. In addition to that, if we look at this map of the incidents, this is where a good portion of the incidents had been concentrated. And so we feel like we're kind of getting the best of all worlds if you're working in the sub-prefectures. As far as the data sources, we're going to be getting information on attacks both from primary and secondary data sources. So for secondary data, we're going to rely on media reports, some of the data from Security Insight, the NGO security organization, which has been systematically collecting data from the NGOs themselves on the attacks that they had experienced. But most importantly, we will be doing primary data collection through interviews with administrative authorities, as well as NGO staff and Ministry of Health. The outbreak data that we will use to try to estimate some of the impact on vaccination, as well as actual incidence of measles among other vaccine preventable diseases. We'll be getting from line lists, which we have from the World Health Organization as well as Ministry of Health and the health facility registers. And I'd like to highlight that since 2019, the Central African Republic has been experiencing the biggest outbreak of measles that it has had on date since 1980s. And so this outbreak has been consistently highlighted as crucial by the Ministry of Health staff and other partners when we had visited the CER in the beginning of this year. This is one of the big public health concerns, COVID notwithstanding. And so this is one of the components that we would like to look at through this project. In addition to that, we will be using health facility registers to get information on measles cases specifically, as well as potentially some of the other vaccine preventable diseases. For health service utilization and vaccination coverage, we will be using health facility registers, and we have access to weekly data from International Medical Corps for 2016 until present. So this is a really rich data set that we have disaggregated by each of the health facilities within the sub-prefectures. So we'd like to capitalize on having this program data, which really should give us some of the granular information that it would be hard to imagine we would be able to get otherwise. And for some of the HIV program data, specifically on use of ART, we will be using district reports. Before I go on to aims and methods, are there any questions about the data sources or where we're operating or anything up to now?
So where it says line lists, what kind of information is in that?
Thanks. Yeah. So normally the line lists do have some identifiable data, but we are not getting that. This is the line list specifically for measles, and they're managed by the health cluster, which is WHO and MOH. So for each of the suspected measles cases that are alerted by the health facilities, the line list will include information on who the child is and who their parents are, their age, when the symptoms had begun, when the facility was alerted of this potential suspected case, when the sample had been taken, when it had been received by the Institut Pasteur, which is the one that processes all of the measles samples in the country, whether the test results had been positive, so whether it's a confirmed measles case or not, if there is known outcome, while knowing that some of the data gets missed a little bit, as well as which health facility the case had been referred from, including health district, and sometimes, but not everywhere, they'll include also the village or the community from which the child had been, where the child lives. I think some additional information that's included in some of that is whether the child is coming from a host community, an IDP, or a refugee setting, but I think that's also not present in all of the line lists. Trying to remember if there's anything else, but those are the key, the key information that is in the line lists.
Okay, thanks.
Mm-hmm. Okay, so then with regards to aims, the first one is to evaluate impact of attacks on utilization of essential health and nutrition services. And here we're really picking just a small part of the essential health and nutrition services. We're not going to look at all of them. So specifically, first, we just want to look at the effect on utilization of the services. And we'll look at outpatient curative consultations, sexual and reproductive health, and outpatient therapeutic program. The ones that we had identified as key morbidities and key type of consultations in this specific context. For outpatient consultations, we'll look at the total consultations. We'll look at consultations for malaria because that is still the #1 morbidity for which consultations are carried out. We'll look at the total consultations for malaria, and we'd also like to look at percentage of consultations that are severe. And that will kind of give us a proxy indicator for delay in seeking services, especially if we're anticipating that more people will be waiting to come because of some potential issues with this attacks. We look at acute respiratory illness and diarrhea because those are the top 3 morbidities in the country. For sex and reproductive health, we look at antenatal care as well as deliveries. In hospitals, we'll include cesarean sections as well, both in the absolute number and the percentage of all health facility deliveries. And then outpatient therapeutic program, which is there to provide treatment for children with severe acute malnutrition. We'll look at admissions as well as some of the performance indicators like dropout and cure rates. For AIM-1B, we're debating whether to include this, and we have some very heated conversations, is whether we can use the findings from A1A to actually project the excess deaths that would have resulted, that may have resulted from the cases of the ski morbidities that were left untreated following an attack on healthcare. And so for this one, well, we'll get to it a little bit more of methods, but we wanted to use some of the methods that had been used in lists, the LifeSafe tool, as well as some of the studies that have attempted to estimate excess deaths from malaria, tuberculosis, and HIV following Ebola outbreak, for example. For AIM-2, we'll be working on evaluating impact of attacks on vaccination coverage and about outbreak of vaccine preventable diseases, but we'll skip that for now for the purposes of time. And the third one is on HIV and AIDS. So if you're curious about those ones, I'm happy to discuss if we have time at the end. And so for AIM-1, the big kind of danger and the reason why I'm here today, the really big concern that we have and a debate that's still ongoing is whether with the methods that we are proposing, we can actually talk about causality. Can we establish that what we're seeing is in fact impact of the attacks on healthcare and not something else? Or should we drop down level and talk about association, risk factors, etc.? And we're really hoping that we can use methods that are robust enough and that we can take into account all of the necessary factors to establish this causality and to talk about true impact of attacks rather than things that may have happened and maybe it's just associated with the attacks themselves. And so I was really hoping to get some of your feedback today on whether you think that what we're proposing is reasonable or it's just pipe dreams and I should just quit and go home. And so with regards to causality, the reason why we started thinking about this is that in some health facilities, what we're seeing from preliminary data, which was provided to us by the International Medical Corps, is that there's definitely something happening. In the health post of Irabanda, for example, you're seeing here the number of doses of vaccines that had been administered. And so this is data from 2017 to 2020, but we do have data for 2016 as well. And we see that through most of 2018, there had been some doses of measles vaccinated. There's definitely some sort of weird stuff going on, but it's a non-zero amount of doses. Then in the middle of the year, the head of the health facility had been murdered. And then we're seeing that there was no vaccination going on. Similar to that, the Penta 3 vaccination, exactly the same thing. There had been vaccination going on with some interruptions before 2018, but then after this murder of the health facility, there's nothing. So the question is, was this because of the attack? Was it because the head of the health facility had been murdered? Or could have been something else? I'm sorry. So was it because potentially something else had happened and it just happened to have coincided with the murder of the head of the health facility? To complicate the matters even further, if you look at other health facilities like this one, the health post of Dangbatro, which is located in the same area, the top graph represents the curative consultations. So total curative consultations that had been administered in this facility. And at the bottom, we see antenatal care consultations. Similar thing, there was a pillage of a health facility, there was nothing going on, and then some things had started up. So here, this was a mobile, oh, sorry, I realize you can't see what I'm pointing at. Yeah, here you'll see that there's something that happens. This was a mobile clinic that had been carried out. And then here we know that the facility had opened. So again, was this gap because of the pillage? Was this, to what extent and to how much time can we say that pillage was something that had led to this change? To get even more gnarly, we look at Dangbatro for vaccination. Same thing, the same thing that had happened. It's the same facility. There had been a pillage. There was no vaccination, probably because of the pillage. But if you look at the time period before the pillage, there had already been a gap. There had been no vaccination for most of 2017. So how much can we actually attribute to this pillage and how much had been due to other secular events? And so how are we going to try to how are we going to try to answer this question? Well, so for the first aim, for the effect of attacks on healthcare utilization of key and health services, we're going to essentially proceed along this gradient of what assumptions we are willing to make. So we'd like to essentially tighten the assumptions along each step and see then how much the estimates change, and within each context, specific context, by sub-prefecture or within even lower geographic units, think about what assumptions we think may have been reasonable and what can we comfortably say would have been an appropriate method. And that raises a whole set of other questions. But first, we'll get non-parametric estimates and bounds. We'll use interrupted time series as our next step. Then we'll also introduce controlled interrupted time series, and we're considering using matched and synthetic controls as well. And then we'll tighten the assumptions a bit more and say, okay, let's do difference and difference. And one of the reasons where we're trying to explore these different options, even though some of them may seem a little bit more reasonable than others, is that we would like to learn about what kind of methods we can use in this setting, but we'd like to make some recommendations for other case studies that are going to be done in Afghanistan as well as in Colombia, so that we can say, you know, if somebody wants to do this in the future, what kind of things should they consider? If they're more comfortable using difference and difference, how would they decide whether that's appropriate in their setting or not? So we want to do that in ours and then say, well, you know, maybe this is what we're comfortable with, maybe it's not. We definitely want to acknowledge that there's a lot of variation within seasons as well as within some other temporal and spatial patterns. And so we'll fit some models to time series data for the indicators to try to take into account spatial as well as temporal variation. And we will look at some potential spillover effects at neighboring health facilities. For example, if we know that one health facility had been closed following an attack, if we think that the population was able to access services at a neighboring health facility that was maybe 20 kilometers away, then we definitely have to address that. So we'd like to extend the unit of analysis to include the neighboring facilities if we think that that would have been the case. So essentially decrease the granularity of our unit of analysis, but also we could just look at what happens in parallel at the neighboring facility.
So if I,
yeah, go ahead.
This is excellent. Thank you. It's very impressive what you're doing. I mean, my first thought on the question, your AIM-1A question, is that if you're seeing that right after a pillage or murder of the leader of the health facility, that services go to zero for a while, and it's not, if that is happening somewhat frequently, and you don't have that many breaks like that where things go to zero otherwise, then I think it's a pretty clear case. I'm not sure it's just to put it out there that I don't think it's necessary to for that question to do any more analysis than that. I think it's just a very clear. Others can. I encourage to, if you disagree, but that seems very like that's very strong evidence that it's because of that. Yeah, I just put that out there.
I think this is like a really interesting case of interrupted time series, because the difference is so stark that it's sort of like it almost ceases to be a quantitative question. It's just like, trying to isolate or prove the cause of a specific event. And I think that's kind of hard. I would almost be more convinced if you could go to someone who works in the health service and say like, hey, did you all stop giving out vaccinations because this person was murdered? Like that would almost be stronger evidence to me, but I don't want to sound like too much of a heretic.
No, I completely agree. And I think for the really stark cases, like going to zero, yeah, I think it's hard to say, and especially because we do have the contextual knowledge. We are going to be doing interviews. Some of us worked there for a while. So we definitely know, oh, health facility closed. Okay, yes, that makes sense. I think where it does become a little bit more murky is where we don't have, and I have some examples of that, maybe I'll just jump to that, where it's not quite as clear. So you do see some other things that are like this. You know, this is an example here for Irabanda where, yeah, okay, the guy was murdered, everything closed down, there's nothing happening, probably because of this murder of health facility, of the head of the health facility. Unfortunately, then actually in that situation, what may happen too is there was some other event that had taken place in the middle of 2019. And because of that, the facility was not able to reopen. And so at that point, do you attribute the zeros for the end of the 2019 to the murder of the head facility, or because there had been some other event that had prevented it from opening as it had been planned? So that's actually not a very good example because that's more of an effect modifier. But there are, you know, if the whole village had been burned down and everybody had been killed, which has happened in 2019, then at what point do you decide that the impact of the murder of the head of the health facility had stopped and there had been something else that went in? On the other hand, you also have something like this, where you had 2 attacks, but it doesn't look, honestly, like it had done very much, even though, again, the head of the health facility in this facility had been murdered. And so we kind of, and there are different ways in which we can explain that. For example, here, this is for antenatal care. So even though the head of the health facility was murdered, it's the traditional birth attendants that are taking care of the antenatal care. So maybe that particular service wasn't affected by that event, but vaccination was, because the murder of the head of health facility meant that he was also the only person that was doing vaccinations. So which services were affected and how, and to what extent do we consider indirect effects? If somebody knows, if the head of the health facility was murdered at the facility and the population now fears going to the health facility because they think that there is no protection, there is no safety, the armed groups are not respecting the humanitarian law, they may be killed if they go, then maybe another service will also be affected, even though that effect will be indirect. So that's kind of, and I think there are a couple more examples if my slidey thing would actually work, which unfortunately is not doing, so I'll just have to exit it again. But completely agree with your point that if it's a very stark effect, there's not that much debate, but there are some situations where it's a little bit less clear, and those are the ones that are really giving me the headache. We are also hoping to do kind of a conceptual framework development with some of the partners on the ground so that they can help us understand why these changes had happened. And we are also trying to understand some of this more secular events, which, I'm sorry, I'm trying to exit and it's not exiting. I'm gonna stop share and reshare again. Because there had also been some of the more general conflict that had been happening. And for us, one of the challenges that if you're seeing the common conflict, the general conflict as a common cause, which is then resulting in these changes in the behavior and utilization and availability of services, but at the same time are also a cause of some of these attacks on healthcare, then how do we take that into account and what becomes our cause? What is impacting utilization? Is it the attacks on healthcare, or should we be looking at that more general instability on conflict? Sorry, I'm gonna try to reshare again. Thank you for your patience. This is embarrassing. Don't know why it's happening.
No, it's no problem. Don't worry about it. Are you able to read the comments in the Zoom, or is it because?
Yeah, let me look at them. I had it full screen, so I couldn't see them, but I will pull them up now so I can see. maybe I'll just skip the small
I would
one.
try to summarize it, but I don't know if I can. But if someone else
Okay.
can, then
Oh, I can see it now. Thank
Okay.
you. Yeah, so the comment about the death being the common cause because general stability is impacted and someone getting killed is not surprising. Yeah, and so there is a distinction on, for example, somebody getting killed, and how do we define what is an attack on healthcare versus an attack that happens to affect healthcare but is not actually attack that targeted healthcare. For example, if it's a community health worker that was killed while they were on duty and wearing their special visibility vest, and they had been killed because they are, spreading the message about sexual and reproductive health, women's rights, etc., then that we can probably say, okay, probably an attack on healthcare. But if it's a community health worker that was killed when they were going to the market to purchase vegetables, maybe they had been killed not because they're a community health worker, but because they're just going to the market at the wrong place. And so we do have some distinction in how we're identifying what constitutes an attack on healthcare and trying to tease that out from the general attacks. Now for CER, in some ways, it is a little bit easier than in some places like Afghanistan, where the intentionality makes a big difference. For our purposes, if it's something that was clearly marked as being a part of a medical team or part of a healthcare system, we are considering that an attack on healthcare. If they had been attacked during a larger attack, we're not considering that as an attack on healthcare. So for example, if a village was razed down and the health facility burned together with the rest of the village, we're considering that as a general attack. Now, if only the health facility was burned to the ground and the rest of the community was untouched, then we are considering that as an attack on healthcare. And skipping through a bunch of this other stuff, there is a big discussion around what is counted in kind of the dose response that had been brought up by Naira, where, I mean, not to mention going into Sutwa, but all attacks are not created equal. For example, if we say that somebody had been kidnapped ahead of the health facility, if they were held for 2 days versus 4 months, the impact of that on the healthcare would be quite different. If it's a single versus multiple attacks, how concerned are we about compounding, and how can we take that into account? So do we just model them as, a number of attacks that had taken place? Should we break down attacks as intentionality or based on the action itself? So whether it was a kidnapping, whether it was a murder, whether it was pillage, whether we should classify it based on result type, for example, suspension of services, closing down of a clinic, or maybe a reduction of operating hours or reduction on the type of services. So how do we try to get that all aligned? And I think that really, the reason why I put Sutpa there with a question mark is we do have this multiple treatments possible, and the levels of treatments are not the same. So how do we figure out the counterfactual for each one of them? And that's been giving me a very big headache. And with that, the question of finding appropriate controls, of course, comes up, because there had been a lot of things like general attacks on the communities that had been taking place. And so, for example, if there had been a village that had been burned to the ground and the population had migrated to an IDP camp, and this was a camp that had been built over the course of 1 week for 20,000 people, you know that their outcomes and health utilization practices are going to be different. So if at that time it happens that there had been an attack on a facility, well, how much of the change that we see after that is going to be caused by this or by this, or, and I'm pointing at the photos, but you can see that, or by the actual attack on the health facility. And so some of the suggestions that we had around building the controls was thinking about essentially what we know about the facilities and what we know about the populations that are living in these areas. As an example, in the sub-prefecture of Akaga in the very north, we have 20 health facilities that are supported by International Medical Corps, and that comprises the entirety of the sub-prefecture. So there aren't any health facilities that aren't supported. There aren't facilities that are supported by another partner. All of the facilities are supported by this NGO. So that's also one of the kind of nice things that we have about this. However, the facilities are different in profile. You have one hospital, which is right here, Birao. You also have two health facilities, Sikikide and Tiringulu, which are technically primary health facilities, but they offer surgical support if necessary. So they're kind of like a little baby between a hospital and a health facility. So do you consider them to be in the same kind of a level? Should we consider them, if making controls, to be each other's control, because at least they're offering similar type of services, whereas these other ones are either health posts or health centers. So they have a very different profile of population that is using them. You also have different levels of support. IMC has been supporting some of the facilities since 2007, and some of the facilities they only started supporting in 2018. So should we build the controls based on the time from which they had been supporting? Because you can anticipate that when the support starts, that means that the way that people are using services will probably be different. When IMC supports a health facility, that means all services are free. You probably have more qualified staff present. There's probably a better chain of supplies, including medication to treat whatever your most common morbidities are. And there's also more awareness activities going on in the community to get people to come to seek services. And so if we're thinking about individuals that are seeking care in 2018 in this newly supported health facilities, probably there's going to be some sort of different trends in utilization just because there is that ramp up in activities at those health facilities. So should we use them as each other's control and not use the other health facilities that had already been supported for over a decade, because we know that the trends are going to be different? Should we try to match them based on secular events? There had been some armed group activities here before. There's been some displacement in there. Should we try to tease them out that way? Or what are we really doing? Should we just give up? And so that has been a lot of trouble. Should we try to match them on parallel channels before attacks? So we're kind of bouncing a lot of these ideas off. We do think that we'll get some better idea once we do some interviews after we get the IRB approval from Central African Republic on how to do this. And so, if the individuals who are actually there can help identify some of the things that we think may be crucial in trying to take into account when we're building controls, then maybe that will help us elucidate. I do worry it will lead us just to more confusion instead. So that's something that I'm trying to think about ahead of time. I see there's a question, so thank you. All right, so clear that attacks are decreasing in utilization on average. A question is what factors might lead to resilience despite attacks? Thank you. That's a really, really important point. And that's one of the things that we were hoping to get through this exploration, is try to identify some of the potential mitigating factors. We were hoping to get some of the facilities that were not supported by an NGO, especially an international NGO, to try to see whether the kind of resilience that may be experienced at some facilities could be explained by having support of an international partner. In an often case, we do have some anecdotal evidence that that is the case, because usually international organizations can come and support you when something is happening. Well, not usually, sometimes in some situations. And at least there is some sort of support as far as psychological first aid and then longer term mental care as well that is offered to staff that is at the health facilities that are there, as well as some more comprehensive health services that there had been some other types of violence or effects that would need care. In addition to that, one of the things that may be interesting from a resilience standpoint is to see which services are more resilient. One of the things just looking at this preliminary data is that pretty much no matter what happens, it seems like vaccination is the first to go. And there are many, many reasons why that is happening in the CAR. One of which is that the cold chain is not very well established in a lot of the health facilities. And so they rely on this passive cold chain where individuals will go on a bicycle for like 25 kilometers, live in an ice box. And so when there's any sort of thing that happens, they're probably not going to be doing that for a while. Whereas the facilities that have a more, an actual fridge they may be more resilient to changes in vaccination activities. And so trying to identify which services may need more support following specific types of attacks may help us identify where to allocate our resources and how so. In addition to that, maybe some factors that would play into the resilience would be the type of community where it's being operated. So whether it's a host community or an IDP community, within what type of a sub-prefecture, because the ethnic profile is very different. And that also means that has huge implications in the CER with regards to access to services, access to markets, as well as health-seeking behaviors. Other than that, I'm not entirely sure right now what else could come up as resilience factors, but that's something that we're hoping to find out as a part of this project. I feel like I've hopped a lot across and only went over like a third of my slides, but I want to spend the rest of the time on other questions and comments as well as suggestions, because this is really helpful for me. Yeah, there's another comment on, sounds like comparing impacts of events on outcomes directly impacted versus not impacted will be helpful. Yeah, I think that's something that would be at least useful to have, because as a deliverable of this, what we're hoping is not to know, do attacks on healthcare affect what's happening? We know they do. The question is how much and what is the difference, kind of what is the variability in the services that are being affected, and what are some of the direct as well as indirect impacts. Are there any other questions or suggestions? I'm sorry, I know this is not particularly organized. I can go back and do other things, but I'm hoping there's more questions.
Do you have any indicators in the data at the local or regional level about sort of the background stability of the region, and like whether that, like if I was skeptical of the importance of attacks, I would say the attacks are just a symptom of some underlying cause, but you could possibly measure that, right, if you had other variables.
Yeah, we're hoping to. And so over the course of this very long and painstaking interviews that we'll be doing, we'll be trying to tease out other things that had happened. And so, and that's the reason why we are considering the sub-prefectures as kind of their own units, because at least within the sub-prefectures, it was the same armed groups that were operating. And they were, thankfully for us, rather consistent in what they were doing along the different directions. So for example, in Otkoto, the central city is Bria. And from that, there are 3 big roads. So when they set up barriers, they very conveniently set up barriers on all the roads. So in that sense, there is at least some sort of kind of a built-in control in what had been happening. But if there had been some attacks that targeted specific villages, for example, or in some neighborhoods, we do have some information on that, and we will be getting more of that information from interviews. Thankfully from us, IMCA reports to like 12 different donors, and they have to do that very, very religiously. And so the information on, for example, there had been an attack, we were not able to go to a health facility. All of that is in their reports. And so we're hoping that even though we're looking back a couple of years, we are going to be able to get at least dates of what had happened as far as general instability, conflict, displacement, other types of activities like elections, which are coming up right now. And then try to integrate that into our models so that we can take that into account and not, try to at least somehow adjust for that instead of just saying that everything's due to our attacks. But I think that question will remain of, well, is the attack on healthcare caused by this larger underlying thing that's been happening? And I'm not sure we will be able to answer that question. Because then we're also getting to intentionality, and that's something we've debated a lot of the time. For example, there's good reason to believe that armed groups are not pillaging health facilities because they hate the health facilities. It's more because they want to sell the drugs and the supplies they find on the market so that they can fund themselves. And so in that sense, the intention there may not have been to hurt access to healthcare, but it may have been to just make money. So does that really make a difference for us, what the intention was? We decided to go with no right now because there's also no way to really identify that for a lot of these attacks. But that is something that is a limitation, because even the perception of the community of what was the motivation for the attack may affect how they're reacting following the attack. Is there an IV you can explore, something that triggers attacks? I have no idea. We thought so hard, but in this case, I could not come up with one. If you have an idea, I would be so happy to hear it, because I've tried so a sleepless night trying to come up with an IV. But one of the things that I'll mention, in the sub-prefecture of Otkoto, almost every facility had been attacked at some point. And so I was trying to think of something there, more of like an IV for when an attack will take place. But up to now, I have not been able to think of one. And for that, we were also thinking maybe doing something like a sub-reg analysis. But I don't know. Some places are less accessible. Yeah. Whether, maybe. I don't know. There definitely been some attacks that took place during all of the seasons. It's pretty much like a year-round adventure. Unfortunately, they don't stop. It's just one of the things that we could look is the type of an attack different? So that's something that definitely could have played an effect. Yeah, maybe sub-prefecture or the distance. Yeah, distance to the central city. Maybe. We were even thinking maybe population size or kind of the ethnic makeup of it, but it's not really an IV in itself. Yeah, no, those are all really good ideas. I think I'll take that up with the upper people and see if we can get some idea on what could work. Thank you. All the best wishes, very much appreciated. We'll definitely need it, and I'll need a lot of support. So I appreciate your comments.
I have a big picture question, and I'm sorry if I missed this. I had to deal with a tantruming toddler in the middle of your talk, but are you thinking about the downstream policy implications for what you learn, or like what types of policies are even in the realm of possibility here?
Yeah, thank you. That's originally what motivated me, other than my undying loyalty to the Central African Republic. But there's been a lot of discussion in the international humanitarian community on the kind of policies and implications for enforcing the international humanitarian law. And there has been a lot of it, and I know this is recorded, but I doubt a lot of some of the
I can turn off the recording if you want.
It's okay, nobody will listen to this. A lot of the implications around how to actually implement it, right? And so there has been some discussions at WHO, as well as at some of the other humanitarian kind of forums, on what laws and what kind of advocacy needs to be made, both at country level as well as international level, to try to discourage armed groups from attacking healthcare. And that's been raised much more with what's been happening in Afghanistan and Syria and some of the other places where that's been a little bit more visible. Whether this particular study will change that remains unclear, but there has been some indication from this more larger bodies that this kind of evidence, or at least something that is going to be a little bit more tangible and quantifiable, may help support some of this push towards higher levels of advocacy. Now, at the country level and even at the more local level, I would say that this could have some potential impact. And from my limited work with some of the leaders of the armed groups, they have been receptive, at least to a certain extent, in hearing about how certain things affect the populations, because ultimately the people that are going to be affected are somebody's people. And the armed groups often are operating in their own regional areas, and the people that are affected are their own families, their own communities, their own ethnic groups, their own religious groups. So whatever kind of identities you can pick, there's probably somebody in that area that is going to belong to it. And so organizations like International Medical Corps, has been successful in securing passage, even during conflict, to access areas to provide medical care. So the hope is that if we are able to produce this kind of work and go back and essentially tell the armed groups, like, look, over time, when this kind of things happen, this is what's happening to your community. This are some really long-term implications. This is really affecting, you know, this groups disproportionately. How can we work together on trying to make sure that this doesn't happen? And maybe it's a pipe dream. Maybe at the end of the day, things will continue on as it happens. But there's like a non-zero probability that maybe something will change. Whether it's a completely inconsequential, insignificant change remains to be seen. But the concern is that if we don't do this kind of work, then we will not really know, and then it's just going to be more of trying to speak and appeal to people without presenting as much of an evidence. But I don't know. We'll find out over time. Especially if something happens like this overall, there's not really an impact. That's going to be a bad news bears for us. So I'm really hoping we'll see something. Yeah, but at least from the mitigation perspective and something that can be a little bit more actionable, if we can identify that some groups are more disproportionately affected and that some services are disproportionately affected by certain types of attacks, then hopefully that can help us develop some mitigating strategies that can reduce the excess morbidity and mortality over time.
Any other comments or questions for the speaker? If not, I think we'll end things there. That was great, Natalya. Thank you very much.
Yeah, thank you. And please keep us posted. Now we're all going to be curious to see how this plays out. So come back and present again.
Yeah, anytime.
Okay. Thank you so much. Thanks for having me. It was a real pleasure. And thank you for all your feedback and suggestions.
Thank you. See you later, everyone.
Bye.